Hello, everybody. I'm glad that we have such a great turnout for this symposium that's sponsored by Eurofins and Transplant Genomics. And so I just want to first thank the audience and thank this distinguished faculty panel that we have to comment on both the heavy side of immunosuppression and the light side, basically looking for evidence of rejection under the cover and looking for opportunistic infection, using biomarkers to help guide our therapies and guide our decision making. So again, this is called Making the Case for Novel Assays, Balancing the Risk for Infection and Rejection. We will have a first session, which is about half an hour with each one of our speakers, and I'll just introduce them very briefly. Michael Marvin is the professor and chair of the Department of Surgery and Transplantation at Geisinger. Nicola Lecca is a professor and medical director at University of Washington Kidney Transplant Program. Mike Bunnapradist is the professor of medicine and research director at UCLA. And Atul Humar is the professor of medicine and director of the Transplant Center in Toronto. So all but one are nephrologists. All but two are nephrologists. I take it back. Marvin, Dr. Marvin is our transplant surgeon who actually acts as one and all at his transplant center. So he does surgery plus all the immune monitoring and immunosuppression for his organization. After we have our three speakers, Dr. Marvin, Dr. Lecca, and then we will follow by having a quick panel discussion where if there's questions from the audience, we'll be happy to take them, and then we will move on to the flip side of the equation, which will be Dr. Humar's presentation. So without further ado, I would like to first have Dr. Marvin come to the podium and provide us with his insights and thoughts on immune monitoring. Thank you.
I appreciate the promotion. I'm not the chair of surgery, just transplantation, but that's fine. I'll take it. Let me just put the slides. Okay, so we're good. So first, we're talking about biomarkers. So what is a biomarker? So it's defined as a characteristic that is measured as an indicator of normal biological processes, pathogenic processes, or responses to an exposure or intervention. There's many different types. We're going to be focusing mostly on molecular, and it's diagnostic. And a diagnostic biomarker is used to detect or confirm the presence of a disease or condition. So it's kind of obvious, but just a little background first. What's the reason for this? Subclinical rejection has been demonstrated in about 25 to 30% of transplant recipients in the first 2 years. That subclinical immune process that's going on without our knowledge leads to immune activation and long-term increased risk of all the stuff that makes kidney transplants fail. DSA, progression to IFTA, and of course a more rapid loss in renal function. So the only way we can find subclinical rejection, at least before these biomarkers existed, was protocol biopsies. Now, just poll the audience. How many programs actually do protocol biopsies? So you got 1, 2, 3. So 3 people out of everybody here. That's maybe, you're all probably from the same program. But maybe 3 programs out of all the programs that are here do protocol biopsies. So there's no way for us to really know. Plus, protocol biopsies in and of themselves have risks. It's not the most accurate. You can at most, 20, 30% of the time, it doesn't even, they're normal. And so it would be really nice to have a non-invasive way of determining what's going on. Now, this talk kind of works well with what's happening in the next half hour, which is about CMV. So CMV BK is right, the bane of our existence after transplant, other than rejection. On the other side, it's CMV and BK. So what do we typically do when we get an infection? Reduce immunosuppression. So when you're reducing immunosuppression, there's a battle between risk of rejection and then getting rid of the infection. So it's a really difficult thing, and typically protocol biopsies or surveillance biopsies would be something you would do. But I'm sure, are there the surgeons in the room? I'm sure many of us have had to go to the operating room emergently because of bleeding after a kidney biopsy. Thankfully, it's rare, but it definitely happens. And those are true emergencies. So biopsies are not without complications. So the FDA has a guidance of of how to use a biomarker, and it looks at a context of use. So we would love to have a non-invasive diagnostic biomarker for surveillance of subclinical rejection. And so we're focusing here on TruGraf, and this technology for gene expression profile, TruGraf, has been around for a long time. TruGraf is the only one that is on the market for kidney at the current time, but there's tons of data, and I'm certainly not going through all of these abstracts. But the point is that there's a lot of data to back up this science. Now, TruGraf has switched. If you look at some of the early studies, the numbers, every study seems to have a different number. But initially started as a microarray, which was the technology used to actually perform the test. And then they switched to PCR. And what that PCR has been able to do is it increases both your positive and negative predictive value. So it's much more sensitive at picking up subclinical stuff that you don't know what's going on. And if you think about it, if everything else being equal, what's our main indication for being concerned about our graft? It's creatinine increase, GFR going down. But we do living donors all the time, and we take out a kidney, which is roughly 50% of the GFR, but the creatinine doesn't double. The GFR actually doesn't go down by half. And so the creatinine is just not sensitive enough to pick it up. So this is a nice test to see what is going on subclinically. And so in ruling out rejection, the negative predictive value is 91%. The positive predictive value is 65%. So a non-TX, which is how and we'll go into that in a little bit, doesn't necessarily help you as much. But on the negative side of it, along with the CMV-BK issues that we talked about, having a TX or a transplant excellence, things look good, helps you in reducing your immunosuppression. At least that's how I use it. So can TruGraf prognosticate outcomes? Now I'm going to hand this off.
All right. So, Alex, thanks for the introduction. So, we heard about TruGraf in the context of surveillance and monitoring and maybe risk stratification. But I want to show you some data that's emerging now in relation to association of TruGraf with stronger clinical outcomes. This is a recent paper from the Mayo Clinic. In this paper, I think it's worth spending a little time just to think about the epidemiological setup of this paper. It's run at the 3 Mayo sites. There were 240 adult kidney transplant recipients that were enrolled, and they were monitored with surveillance biopsies, which were performed at 4 and 12 months. TruGraf was performed at 1, 4, 6, 9, and 12 months, but it was blinded, so there were no clinical decisions that were made in relation to the results of TruGraf. And the purpose of the study is to assess this composite endpoint of graft loss or death, IFTA grade 2 or higher, and development of de novo DSAs. And as you can see, the subjects were monitored in the first year. We have practically a separation of the incidence, Kaplan-Meier incident curves of rejection between patients that had no non-TXs, so they had only TX results of their TruGraf, and those that had one non-TX versus those that had more than one non-TX, which effectively means 2 or more non-TX results, which, as you can see, had a much higher incidence of rejection. Of note, there were, in addition to the surveillance biopsies, there were 112 for-cause biopsies, and also notable is the median time to non-TX was 30 days, which means that 50% of the non-TXs were in the first month assessment. This is the main result table of the study that shows that all-cause biopsy-proven acute rejection had a higher incidence in the more than one non-TX, so 2 or more non-TX group at 48%, 34% in one non-TX, and 27%. Overall, quite substantial rates of rejection, you could argue. Below that, you can see that most of the differences were actually generated by the subclinical rejection, which had an overall incidence of 23% in this study. And for cause, biopsy-proven rejections were not statistically different between the groups. There was, however, a significant difference in GFR, which was deteriorated significantly in the 2 or more non-TX group at 47 mLs of GFR versus 51 in one non-TX and 59 in the group that had had all TX results. Also, a statistical significant increase in the rates of IFTA grade 2 or higher. Only 3% incidence in the TX group increased to 12% and 13% in the 2 or more non-TXs. Development of DSAs and BK, although it was increase in numerical order, there was not statistically significant. Also, these patients were followed for a median of 3 years post-transplantation, and that censored graft survival was inferior. As you can see, there were no graft losses in the one non-TX or all TX group versus the 2 or more non-TXs that had a statistically significant increase in graft failure. And also of note is that all episodes of graft failure have occurred after 1 year after transplantation, which is not surprising. I just want to switch gear to maybe a preview of data that we'll be presenting today as part of the rapid fire abstract, impact of TruGraf, gene expression profile and track as donor-derived cell-free DNA results on renal function changes over 1 year. This is an interim analysis from the TruLo study, which has this analysis as a planned a priori analysis. It was designed, the TruLo study was designed to detect early associations between biomarker phenotypes, particularly TruGraf and TRAC and renal function over a year of follow-up. And at the time of this report, the time this report was submitted, there were 589 patients that had 1 year of follow-up data. To the right, you see the main table 1, if you want, clinical characteristics of these patients. As you can see, the age, gender, and race and ethnicity match similarly the averages of kidney transplant recipients in the United States. The enrollment period, patients were enrolled at a median of 2.2 years after transplantation. The mean was skewed to the right at 4.6 years post-transplantation. Serum creatinine eGFR at enrollment 54, and the causes of the end-stage renal disease also quite similar to what you would expect in a U.S. transplant population. This is the main result of the study. The figure represents a analysis, a covariate analysis between the baseline GFR, so at the time of enrollment in the TruLo study, and the 12-month post follow-up GFR. Perfect correlate, as you expect, will be a line that has 45 degrees, and as you can see, those two lines, they're representing the all TX values or one non-TX are quite similar to the 45-degree. However, the green curve has a deteriorating slope representing the more than one non-TX values. These slope differences were statistically significant. To the right, you see that the baseline eGFR of the patients that were enrolled in the study was a modifier or of this relationship. So when stratified by baseline GFRs at 40, 60, or 80, we see that differences seem to be more pronounced in terms of deterioration of GFR for patients with a higher eGFR at baseline. So in particular in the group with the baseline GFR of 80, the deterioration of GFR was only 1.7 in the group that had no non-TX values. It was almost 4 for those with one non-TX and almost 13, which is quite similar to the data that was observed in the Mayo Clinic as well. So in conclusion, multiple positive TruGraf tests are associated with a greater decline in kidney function from baseline in a population of kidney transplant patients that have a median vintage of 2 years post-transplantation. This relationship was modified by the baseline GFR being more pronounced than those with preserved GFR at baseline. The results do support the idea that TruGraf gene expression profile can be used in chronic surveillance as a prognostic test for clinical outcomes. and obviously ongoing analysis of the larger database that generated in the TruLaw registry is needed to further validate these relationships.
Okay, so with that as a background and with the information that's been provided as the most current, up-to-date information that we have regarding utilization of TruGraf in the clinical setting, I think that I'd like to now open up the forum here for the next 15 minutes or so for questions as well as a panel discussion. So I think I'd like to first thank the panel for participating, and I'll start off the question and answer period with the thought that we've now had some changes in our clinical practice that's been informed by intended use language changes by MolDX from March. And so a number of us have used that as a way to modify or change our biomarker screening and protocol or practices. And so I'm curious about how you as clinical experts or clinical utilizers in this area, how that has really affected your use. And I'm happy to just go down the list. And we'll start first with Mike. I think you're interested in...
Which Mike?
We'll go Mike Marvin first. How about that?
Yes, so just for those of you who don't know, MolDX is the molecular diagnostics for Medicare. They're the organization or the branch of Medicare that approves and pays for these tests. And they came out recently and said essentially you can't order both. So there used to be Omnigraph, which was marketed, which was a combination of a cell-free DNA and a gene expression profile, and that's no longer covered by Medicare. Now, I'm at a place called Geisinger in central Pennsylvania. We have our own insurance company. We still cover the Omnigraph, so we can still order that on our patients that have that insurance. So it's very insurance stipulated and controlled. Not a surprise, right? But so what we've done is essentially separated for our Medicare patients the surveillance, like I mentioned before, the BK, CMV, those patients normally you'd like to know there's no immunologic activity in the background. So we'll order a TruGraf, and those are patients that are otherwise stable from a renal standpoint. But for those that actually are having some issues with the renal function, then we would more often order a donor-derived cell-free DNA test. So that's how we kind of split it up, because you can't order the test together.
So for us now, we can only order one test, which basically would be, if we're gonna do the test here, would be the TruGraf in stable patients. And we used to do them at the time of biopsy, which we cannot do them anymore. We usually do a test, and if it is positive, and I go ahead with that, we would do the second test first. This is before we got the data from the Mayo. So after the first test, we would tell the patient that the risk of having positive rejection would be about 50–60%. And if the patient's stable, I say we're comfortable repeating the test in 2 to 4 weeks. And if it's positive again, we would go ahead with a biopsy. With the MolDX wording now, we also coming up with the protocol of how we would do it. I think that what they want to see, if the test positive, what would you do? Would you biopsy or not biopsy? So even though we're not a protocol biopsy center, we actually have a protocol on who to get a biopsy.
So it sounds to me like you're using it very similarly in June as you were, say, in April as it was in February at this point in time, because you have an action plan for what to do with the surveillance results. Is that a fair statement?
You know, we use all the tests that are available that you see on the paper, and depends on the preference of the physician. We have 7 of us, but routinely we haven't changed much. We order the test as clinically indicated, or we think it's good for the patient. I think anyone who get a transplant are at risk for rejection. The question at what high risk. One thing that we did though is we define higher risk patient as patient who have PRA more than 80%. Patient had history of rejection before, patient who have DSA before, as patient who we think should be having routine monitoring.
Okay. Dr. Lecca?
Yeah, similarly for us, first of all, I want to step back a little bit. I think the biomarker introduction in clinical practice has really got us a major step forward in terms of individualizing the immunosuppression. So we do recognize the value of this biomarker. Similarly to what Mike Bunnapradist has said, our protocol includes surveillance, although we do not specify the test that needs to be done for those patients. We also have somewhat of variation in practice among the nephrologists, and we've not had enough data, or at least our interpretation has not been that we had enough data to impose one test versus the other. But I think there are, it is unfortunate that we have to order just one test. I believe that all of us agree that probably one single biomarker test is not going to be sufficient for where we want to be in kidney transplant monitoring. But yeah, we try to individualize the care as well as individualize the biomarker screening that we have to do.
We do have a question from the audience.
So basically, the question that I had was, is it only for kidney transplant population, or are we also talking about other solid organ transplant population?
TruGraf is the kidney biomarker. There is one for liver, but that's a different test. So we're talking about here is just kidney.
Great, thank you.
So I think that moving from protocol development to interpretation of results, I'd like to maybe hear how each of the faculty used the test results once they see data on paper. So you have a protocol or a process in place. You have a test result in hand. So you have a non-TX result that comes back. What do each of you do?
So if we get a non-TX, it totally depends on the environment, right? So you'll be checking DSA, you'll check your TAC levels, your immunosuppression levels. You'll obviously look at your GFR, your creatinine, and how the kidney's functioning. If everything else is okay and you have a non-TX, we'll just repeat it.
Okay. In some time frame.
2 to 4 weeks, like what Mike had said earlier, depending on how worried you are.
Yeah, so
And if you're actually really worried and you have other clinical indicators, then you might just go right to biopsy with one. But one non-TX isn't enough. The negative predictive value is really the kicker as how to use this test in my mind. The positive predictive value being 50, 65%, depending on the study you're looking at, makes it a little, you can't just have a knee-jerk reaction to necessarily do something, because then you'll stop using the test because you'll say, well, it was non-TX and I biopsied and the biopsy was fine, so why am I using this test? You have to put everything together.
Mike?
So for us, if we get a non-TX, we would repeat in 2 to 4 weeks, but we also looking at optimized immunosuppression. So if they are on lower than target tacrolimus on lower dose of mycophenolate, we probably want to optimize and repeat the test. On the contrary, the use of the TX to decrease immunosuppression, I think there are some paper abstract coming out. I'm not really sure, I have to see more data. I would not use a normal test just to cut immunosuppression. I think I would think about, does patient look old immunosuppressed? And you could argue everyone is, right? But a younger person, I think it's very risky to cut immunosuppression. Older or patient have side effect and they are TX, maybe in that subgroup I would cut immunosuppression down and repeat. But I would not just cut everyone because they are TX. So TX, I usually do nothing.
For a non-TX, do nothing.
For the TX, I would usually do nothing. For the non-TX,
Yes.
I would optimize immunosuppression
Got it.
and then repeat in 2 to 4 weeks and looking at biopsy. Unless they are very highly likely to have rejection, I would offer them with the first one.
Okay, good. Any differences in your practice, Dr. Lecca?
I mean, the true value is on a TX, right? So having a group of patients that consistently test TX provides you that reassuring. In our experience, the non-TX not necessarily always means some clinical rejection. There may be other things that may need to be considered in the context of that patient, otherwise the practice is definitely similar for those where there is definitely consideration for subclinical rejection. Repeating the test, maybe optimizing the immunosuppression.
Yeah. Dr. Weiss.
So how often when you repeat the test when it's a non-TX, does it wind up changing? And I guess the follow-up to that is, it just seems like that a TX, non-TX, if it was more nuanced, maybe we could maybe do something more with some of these results. I mean, let's say you had a non-TX and it was right at the threshold of being TX or not, and then you repeat it, and then it's right below that threshold. I guess it kind of gets to this whole idea of what does the result mean when it's a non-TX, and how are we going to use it in clinical practice to not just do normal biopsies or more normal biopsies?
It's a good question. They've been talking, the company's been talking about having a number like with the cell-free DNA, but that has not made it to prime time yet at this point. So I know that's something that they want, because for that exact reason, then you can trend it, and it's not just a binary, TX or non-TX. That's a challenge.
I sometimes call the company asking for the number, so I cheat. So I can see if it's just a little bit under or a little bit over. But what I tell the patient is this: I say if two tests are positive, at least 60% chance of rejection. So we probably would want to know. I would recommend biopsy, but telling them that there's a 40% chance that I won't see anything, and that would be reassuring. So we're coming from a non-protocol transplant center, and we do know that if biopsy doesn't have the potential complication, we would biopsy every time patient in the clinic, right? But we can't do that because of the complication, and someone cannot get biopsy. I would see 40% risk of rejection is high, but I do see normal biopsy occasionally as well.
So, I mean, I think the question is a good one. So the bottom line is that we usually want to, if we have a non-TX, we want to confirm before moving forward with clinical action. Under most circumstances, a non-TX or a TX might make us feel comfortable in ongoing management. I think that the real goal for all of us as clinicians is to try to dial in immunosuppression to a more, the lower in a safe way, the better. And I know that there have been some biomarker-driven immunosuppression reduction trials that have come and gone, and unfortunately have not succeeded in prior eras. Just looking at DSAs, looking at other technologies. There has been some. There's a poster that's here today. I think it's a late-breaking abstract from Dr. Petty, who is actually using TruGraf to decrease immunosuppression and use it as a signal for when he's gone too low, and he basically has achieved a MMF reduction of 50% and a lower tacrolimus level. That's one way to do it proactively. I mean, maybe Dr. Humar, you could comment on maybe the reactiveness when you're faced with reduction of immunosuppression in the setting of an infection or something, when we've turned to you and the patient has had BK or CMV.
Yeah, it's a good question. I mean, I think the immunosuppression reduction, once the infection is already established and doing damage, and is much less beneficial, I think, especially if there's effective antiviral treatment, so something like CMV. BK is a little bit different, where we don't really have effective antiviral treatment, where really the prime treatment is reduction of immunosuppression. But even that doesn't work terribly well, and it would be much more beneficial, I think, to be proactive and prevent that viral reactivation from taking hold in the first place.
Yeah. I appreciate your comments, and now I'm going to welcome you. So I'm afraid we're going to have to pause for the next session, which is, again, the flip side of this equation, looking at surveillance monitoring to predict or to manage our patients for risk of infection. So Dr. Humar, thank you.
Yeah, thank you, Dr. Wiseman. Thank you to all of you for taking the time out to talk about CMV. So this is a troll sitting under the bridge, and so CMV is commonly called the troll of transplantation. So I'm going to talk about what's new in CMV, and these are my disclosures and objectives. And just want to start out by saying that CMV is a very complex virus, so it has a genome that encodes about 160 or so functional genes. So just to give you an idea, the COVID virus encodes about 29 functional genes, so you can see just how complex CMV is, and that's why it really modulates the immune system so much, results in this inflammatory cascade that has deleterious effects on the graft. The genes are basically numbered kind of 1 through X, and so on the 54th position of the UL segment of the genome, which is unique long, encodes the DNA polymerase, so that's the UL54. A viral kinase is UL97, and so you'll hear about these when I talk a bit about the drugs. We all know that CMV has direct effects post-transplantation, so most commonly we see this kind of viral syndrome, which is like a malaise and occasionally goes on to fever, but you can get tissue-invasive disease, typically GI involvement being the most common. The key thing is, though, that there are clearly a number of indirect effects. This has been shown both in vitro and in animal models and in epidemiological studies, and this is primarily due to the pro-inflammatory effects of viral replication, and specifically if that replication occurs in the graft, it has the potential to trigger alloreactivity in both acute and chronic graft damage. And so there's two approaches, as I'm sure you all know, to CMV prevention. One is prophylaxis and one is preemptive therapy, with prophylaxis involving giving antivirals for prolonged periods of time to patients, usually starting within the first couple of days post-transplant and giving it for 3 to 6 months. And what's happened is that we've seen that if you stop prematurely, there is an incidence of viremia and disease after discontinuation of prophylaxis. And this has led to longer and longer courses of prophylaxis. So this is the IMPACT trial that looked at D+R- kidneys and showed that 6 months was better than 3 months, but you pay the price in terms of toxicity. You get a pretty significant increase in leukopenia, for example, as a result of extended valganciclovir use. The other strategy is preemptive therapy, which is also actually a good strategy and probably something that's not employed that commonly in high-risk patients in North America, but it involves doing a molecular test, a PCR test, every week for the first 3 months post-transplant and treating early viremia before the patient has CMV disease. And interestingly enough, this is a recent study published by Nina Singh and her group that looked at preemptive versus prophylaxis in high-risk liver transplant recipients and showed that the two, I think they're relatively similar, but it actually showed a slightly higher rate of CMV disease in the prophylaxis arm. And one of the reasons, and this will kind of get to what I'll talk about subsequently, is that when you're on prophylaxis, you tend not to develop an immune response to CMV, and this places you at risk for this late onset CMV. And so what are the new approaches? I'll focus on new approaches for the rest of my talk. So small molecules, cell-mediated immunity assays, and then I'll just briefly mention some of the other new things in development. So let me start with cell-mediated immunity assays. So this is basically a CMI, and the central point, the takeaway point is in red there. So high CMI equals low risk of CMV disease. And typically you determine cell-mediated immune response specific to CMV by stimulating the patient's blood, the T cells or peripheral blood mononuclear cells, with viral peptides typically, although you could also use a viral lysate, and then measuring the output, which is often interferon gamma, but could be other cytokines that are produced by T cells. And I'll just show you the three or four assays that are currently commercially available, and this totally depends on the jurisdiction you live in, what you have available. It's a bit different in Europe versus in North America, and different in Canada versus the United States. But the three commonly used assays are, one is the quantiferon assay, which is very similar to the quantiferon TB assay. It's got a tube that's coated with CMV peptides that are HLA restricted but cover about 95% of HLA types. It's primarily a CD8 detection assay, and you mix the patient's blood in it, and you basically measure the interferon gamma using an ELISA. The next is using an ELISpot-based technology. There's two commercially available assays. One is by Lophius, the other is by Oxford Immunotech, and it's basically what you do is you stimulate the patient's blood with either IE1, immediate early 1 antigen, or PP65, and both of those are immunodominant T-cell peptide mixes. And you're measuring the number of spots that they produce in the ELISpot reader. So it measures both CD8 and CD4 T-cell responses. And you can see in the top row is a positive assay. So you can see there's a bunch of spots forming to IE1 and PP65. There's a negative control and a positive control. And on the bottom row is a negative assay. And then finally, the other assay that has some advantages and it produces this discriminatory CD4 and CD8 data is the TCIP assay by Eurofins. And what they do is it's a flow cytometry-based assay. So you stimulate the patient's blood using a peptide mix, and you measure using flow cytometry, standard flow cytometry techniques, CD4, CD8. There's a lymphocyte activation marker that's built into the test. And this is the kind of data that you get for this. So on the top row is CD4, and you're looking at interferon gamma response. And on the bottom row is the CD8 T-cell response. And basically, the bottom line is if both the CD4 and the CD8 are positive, then you have a low risk of subsequent CMV. If either is positive, only either CD8 or CD4, you kind of have an intermediate risk. And if both are negative, and they use a cutoff of 0.2%, then you have a high risk of getting CMV. Now, how are these assays used in clinical practice? Well, one common scenario is prediction of subsequent CMV after stopping prophylaxis. So if you remember in the IMPACT trial, all the CMV occurs as soon as you stop prophylaxis in the first 3 months after that. And if you could predict at that point who's going to develop CMV and who's not, you could hopefully stop prophylaxis earlier or continue it later if you need to. And this has been shown years ago. This is a study by one of our former fellows that showed measuring cell-mediated immunity at the end of prophylaxis quite clearly predicts who's going to develop subsequent CMV. So if you have a good CMI response, your risk of subsequent CMV is low. And this has also been shown using ELISpot data, and this is a study a bit more recently published that showed that, again, ELISpot positivity, and the positive thresholds vary a little bit from assay to assay, but if you're positive, your risk of subsequent CMV is low. And this is especially true for the R-positive patients. In the D plus R minus patients, if they get induction immunosuppression, a lot of them don't become positive by many of these cell-mediated immunity assays. And then finally, with the same kind of caveats, this is an intervention study, and we're kind of lacking intervention studies. And so what this group of investigators did was they took 150 kidney patients, R positive, and they randomized them to receive either immunoguided prevention versus just 3 months of valganciclovir prophylaxis. And what they found is that when they measured the CMI every month, basically, they were able to discontinue prophylaxis earlier. So for example, if patients were positive by cell-mediated immunity at 30 days, they just stopped the prophylaxis at 30 days. And so, and then they compared it to the standard group. And basically the rates of viremia and disease were quite similar, but the neutropenia was much lower in the immunoguided arm because those patients were getting 57 days of valganciclovir on average versus 90 days in the standard group. So this is kind of an interesting interventional trial that shows that this technology is quite useful. The second scenario is predicting progression of low-level viremia. And we all see this in clinical practice. These patients have very, very low, they have 200 copies or 300 copies. And what do you do with these patients? Most of those patients actually clear viremia on their own, but a lot of centers will actually treat that quite aggressively when you don't actually need to. And if you could check cell-mediated immunity at that point, if they're positive, they're going to clear viremia on their own. And that's what this study showed us several years ago. That's sort of another potential use. And then the final kind of potential use scenario is after a patient develops CMV. So after they develop CMV, a lot of us put patients on secondary prophylaxis to prevent recurrence. And there's not very good data to support doing that, but it's very, very common practice. And I think, wouldn't it be nice if we could decide who really needs secondary prophylaxis and who doesn't? So this is this study where we looked at measuring cell-mediated immunity right after you finish treatment. And if you were positive, we didn't give them any prophylaxis. And if they were negative, we gave them another 2 months of prophylaxis. And you can see in the positive group, even though they didn't get prophylaxis, that's the blue line, they didn't have a recurrence. In the negative group, even though they got prophylaxis, they still recurred after they stopped the prophylaxis. So I think this is a nice potential use of cell-mediated immunity testing. So this is kind of the summary of the pros and pitfalls of using these assays. I think the pros are that, this is really nice to optimize the personal prevention and treatment of CMV using an objective test. There's patient benefit due to decrease in antiviral use and drug toxicity. And there's also a cost savings due to decrease in antiviral use and maybe due to decreased molecular testing. And I think the other place where we've seen a possible use is in these really challenging patients that keep having CMV recurrence. The pitfalls, and I think probably it's clear from some of the studies I presented, is that there isn't really a conclusive demonstration of utility across all those scenarios that I outlined. There clearly is in some of the scenarios, but not all of them. The other thing is the cutoffs are not always clear, and they probably vary from patient to patient depending on how immunosuppressed and what type of transplant they are. And the studies with one diagnostic assays don't necessarily mean that another diagnostic assay is going to work. And the studies I kind of showed you used a whole bunch of different diagnostic assays. And the test approvals really differ a lot by the jurisdiction that you happen to live in. Now, in the second half of my talk, I'll talk a little bit about what's new with some of the therapies and prevention. And this is also important as we try to kind of personalize our prevention of CMV. So this is a little bit of a complex slide, but what it shows is that our main drug, which is ganciclovir, and valganciclovir is a prodrug, is phosphorylated by UL97. And then it's triphosphorylated by cellular enzymes and inhibits UL54, which is the viral DNA polymerase, and it binds to the DNTP binding site of UL54. Foscarnet, on the other hand, binds directly to a different site on UL54 and hence can be used for ganciclovir-resistant CMV. So two new drugs I want to briefly mention. One is letermovir. So when CMV is replicating, it produces these concatenameric strands of DNA, and those strands have to be cleaved so that they can be packaged into the virion. And that cleavage is done by something called the terminase complex, which is encoded by about 4 or 5 different proteins, but the main one is UL56 and UL89. And what letermovir does is it inhibits UL56, thereby inhibiting the terminase complex. It's an oral or IV. It really has it's an excellent side effect profile, so it's not myelotoxic, it's not nephrotoxic. There is some in vitro data showing that resistance tends to develop pretty easily in vitro, but not clear if that happens in vivo or not. And this is the kidney transplant trial. This is hot off the press, so many of you may not have seen it, but it's a D+R- kidney patients, 6 months of letermovir versus 6 months of valganciclovir as prophylaxis. The key here is that letermovir does not work against other herpes viruses, so the letermovir arm has to get oral acyclovir for herpes simplex prophylaxis and varicella zoster prophylaxis. The primary endpoint is CMV disease, and you can see both were equivalent, so letermovir was 10.4%, valganciclovir was 11.8%, but the interesting outcome really here is the adverse events, and the leukopenia rate was 26% versus 64%, so potentially a very attractive alternative to valganciclovir prophylaxis. Not approved yet for that indication, though. The other new development is maribavir, and this is approved by the FDA and by Health Canada and in Europe for refractory resistant CMV. And what's that? Refractory resistant CMV is if you have increasing or persistent viral load after at least 2 weeks of adequate antiviral therapy. And some of those patients, but not all of those patients, will also have demonstrable resistance, so they'll have a viral genetic mutation that confers resistance to ganciclovir. And these are the risk factors for refractory resistant. You can guess it's, too much immunosuppression, subtherapeutic levels of antiviral, prolonged antivirals, and CMV D plus R minus patients. So how do we deal with refractory resistant? Well, it's unfortunately has become very, very complicated, and you can send for resistance testing, and this is the kind of data that you'll get back. So you'll sequence the UL97 gene and the UL54 gene, and thankfully most either private or public labs that do these sequencing do the interpretation as well. So it'll tell you if there's a ganciclovir resistance mutation, whether it's high level or low level. Low level means you can probably overcome it by increasing the ganciclovir dose. High level resistance means that you need to switch to an alternative agent. And this is a map of the UL97 mutations that confer ganciclovir resistance. The UL54 mutations are quite a bit more complex. Some of them confer ganciclovir resistance, some of them confer cross resistance to ganciclovir and foscarnet, some of them only confer foscarnet resistance. So you really need some kind of interpretation when you get these resistance mutations back. So maribavir has a different mechanism of action. It's an oral drug. There's only an oral formulation. It's not myelotoxic or nephrotoxic, so it has good safety profile. The main side effects when you use it in your patients is a taste disturbance. So you just have to warn them ahead of time about that. And most people can treat through that. And it inhibits UL97, which it's a little bit confusing because UL97 is the protein that phosphorylates ganciclovir, but that's not the function in the virus. In the virus, it has a critical function having to do with the nuclear egress of viral particles into the cytoplasm, and maribavir blocks that egress from occurring. And this is the pivotal phase 3 study that was just published recently that led to FDA approval. And what they did was they randomized patients to maribavir or what was called IAT, which is investigator-assigned treatment, and this whatever the investigator wanted. And this is all patients with refractory or resistant CMV. And most of the IAT was either very high-dose ganciclovir or foscarnet, basically. And you can see that this is the results of the study showed, and patients were on antivirals for 8 weeks. You can show a pretty significant improvement with maribavir in the dark blue, which at 56% clearance, versus IAT, which was only 23% clearance at 8 weeks. Now, I'll just spend 2 slides on the other 2 things. So one is adoptive T-cell therapy, and I won't go through the data on this. There's many small studies that show benefit. This involves taking virus-specific T-cells, expanding them, and then infusing them into the patient. They can be autologous or third-party. Third-party is probably easier in terms of commercialization. There are costs and time constraints, but there's been barriers to commercialization for many, many years. This is a pretty niche population, and as these new drugs come out, small molecules come out, this is going to be more and more difficult. But there is a multi-virus specific T-cell product called posoleucel that is in later phase trials, and it has T-cells against multiple viruses, especially BK, which may be of interest to the transplant community. And then finally, CMV vaccines. This has been kind of an on and off story. Everybody always asks me, well, when are we going to have CMV vaccines? And the answer is I'm not sure. There have been several vaccines that have been developed and unfortunately have failed in either early phase or late phase clinical trials. There are a few that look pretty exciting. One is a vector vaccine, and if you recall, the COVID AstraZeneca vaccine was the first vector vaccine that was approved for use in people. So this is a vector vaccine with CMV. And then if you recall, Moderna has a very successful COVID vaccine. They're producing an mRNA CMV vaccine as well that that is entering phase 1 and phase 2 trials. So in summary, I know that was a little bit of a whirlwind tour, but I was asked to keep it relatively quick. I think it's a pretty exciting time to be in the CMV field, and we're entering a whole new era. You can see where there's going to be multiple diagnostic, therapeutic, and preventive strategies that are going to hopefully let us finally get rid of this troll of transplantation. So thank you very much. And I'm happy to take questions, or if any of our moderators would like to add comments or anything that I missed.
I think that was fantastic. And we do have some time for questions. I'll just pose like a clinical vignette to maybe think through the use of diagnostics as well as maybe new therapeutics potentially. Let's say somebody develops CMV, positive to negative, and is treated successfully with valganciclovir, and then instead of necessarily having relapsing, not having refractory disease, but relapsing disease. So negative, and then subsequently becomes CMV PCR positive to the 3,000 to 4,000 copies range. What do you do? How do you think about that from a risk profiling? And then we can talk if we expand that case.
So that's like obviously a super common clinical scenario. At our center, we use a threshold of 1,000 IU to treat those patients. Other centers use any detection. Some centers use higher detection. We don't really know exactly what we're doing. So in that scenario, I would suggest treating them with antiviral therapy. I actually don't suggest lowering the immunosuppression unless it's a liver transplant patient. But for the average kidney or heart or lung, and that level of viremia, they should respond well to antiviral therapy. And so I actually don't suggest lowering the immunosuppression. But that is common practice to do that. I'd be interested to hear what our panel thinks or what others think of that. Certainly if they have severe CMV disease, then you should lower immunosuppression in that setting. And
if the individual is leukopenic, neutropenic, is there an agent that you would prefer?
So certainly for treatment, if they're leukopenic, the best agent is still ganciclovir or valganciclovir, and you should give them G-CSF and hold the MMF if possible, and if they're on trimethoprim sulfa, probably hold that for a little bit if possible as well. So.
There are a number of scenarios that you provided where the diagnostic assessment of cell-mediated immunity was helpful in either reducing exposure to or monitoring response to therapy. So for the patients who are low-level viremic but stable, do you ever later after treatment or after recovery measure CMV IgG levels as a modifying factor for your decision making, or would you use cell-mediated immunity testing?
It's a really good question actually. So the IgG level is the CMV serology. I don't think it's too helpful. Like it may help a little bit, but really the control of viral replication is primarily through the cellular response rather than the humoral immune response. So it's really CD4 and CD8 T cell response that controls viral replication. So I think if you have it available, the cell-mediated immunity testing is a much more elegant way of trying to figure out who's going to control viral replication than humoral antibody testing. Although some patients are hypogammaglobulinemic overall globally, and in those patients it's helpful because you can replete that.
Hi, I'm Rob Carroll from Australia. You make a comment about not reducing mycophenolate.
I knew that would get me in trouble.
So I just want to know what your thoughts are on doing drug AUCs for mycophenolate, particularly at that 3-month mark when absorption of mycophenolate usually is quite high, and whether you would ever consider doing that and then thinking about reducing mycophenolate.
I think certainly if you have that available and you can use that, in Canada we don't routinely have that available. But I think if you have that available and it's clear that perhaps the patient is over-immunosuppressed, then you should reduce immunotherapy. I think the reason I say if you don't know what's going on, then you don't right away need to reduce immunosuppression is because a lot of people think that, the patient has CMV viremia, they're over-immunosuppressed. But that's actually not necessarily true. They're lacking CMV-specific immunity, right? So.
Thank you. Great talks, thank you. Two questions and then a comment. The first one is, in terms of the context of use of this assay, obviously someone who's been treated successfully to decide, again, whether they need a long-term tail for prophylaxis, secondary prophylaxis would be one. What about, we have a new, more sensitive assay where we're detecting low levels of what seem to be replication. Is there any role for that context of use to check and see if they have any T-cell immunity and maybe not treat them?
Yeah, I think, that's an excellent question. I briefly touched on it. I think it could definitely help. So all these patients with, 200 copies or even 50 copies or something, actually about 3/4 of patients with, 50 to 100 copies will clear spontaneously, and they won't rise. So in that setting, if they're CMI positive, if you can do a cell-mediated immunity test and you have detectable, especially if you have both a CD4 and CD8 T cell response, the chances of them progressing are actually very low, and you could just keep an eye on them.
That's great. So. And now I'm going to ask the non-ID naive question. Is there ever a scenario where someone could be IgG negative for CMV but actually have T cell immunity?
Yeah, there's always exceptions, right? So there is, especially in elderly patients, what happens is that the serology might wane over time. So they're CMV negative. By
those
serology,
older patients, right?
Yeah,
we often see that.
By serology, they're negative, but you do their cellular immunity. This is pre-transplant, and they're actually positive. So they've had exposure to CMV, but their serology has waned over time. So.
Okay. And then just to make a comment from the previous talk about TruGraf, because I think the question was a good one that came up about positive, negative, and how you deal with this. And I think, immune gene expression profiles are prone to low specificity because they're a panel of inflammatory genes, right? So they're going to be non-specific. And I think the way to deal with that in our practice has been, if you have a positive, we've seen that where it's positive in the setting of COVID or another infection or some other inflammatory state in the kidney, honestly. But what we know from our serial biopsy studies is that subclinical rejection tends to be persistent. And so that's why if you have a positive and you follow up in 2 to 4 weeks with another positive test, it's more likely that it wasn't a transient inflammatory state, but it's more likely a persistent inflammation in the graft, and that would then change the risk-benefit of doing that biopsy to go in there and do that. I mean, again, that's why the strength of these is a negative predictive value, because the absence of inflammation tends to be helpful in our patients.
Yeah, that's a good point. Yeah. Yeah. Yeah, that's an excellent question. So the question, just in case others couldn't hear it, was whether to switch to an mTOR inhibitor in resistant CMV cases. And our practice has not been to do that. So the evidence for use, and it may be because mTOR is involved somehow in the CMV replication cycle, that there's a thought that switching to an mTOR inhibitor may have beneficial effects. And there's actually very, very good data that shows if you're on an mTOR-based regimen from the outset, you have a less likelihood of developing CMV reactivation. It's a little bit different for treatment, and I think, once you've got viral replication and CMV disease, then, switching to an mTOR inhibitor, I don't think will be terribly helpful. It's really the overall global level of immunosuppression that's the key driver of that refractory or resistant or recurrent CMV, and so sometimes when you switch to an mTOR, you may actually be increasing the global level of immunosuppression there. So.
I know it's off the diagnostic topic, but just the quick question regarding the letermovir and drug-drug interactions. Could you just comment briefly about the degree of severity of interactions between the calcineurin inhibitors and...
Oh, yeah. I mean, letermovir certainly does have drug interactions. Between the calcineurin inhibitors, I don't think it's a huge deal. I mean, especially if you're using it for prophylaxis, you're monitoring their calcineurin inhibitor levels very, very frequently during the first couple of weeks anyways, so.
Okay.
Yeah.
All right, well, this has been a great forum, and I really appreciate all the audience participation. I want to thank the panelists again and the faculty speakers, so thank you.